Hi everyone, I am Dr. Sumit Jain from Department of Orthopedics. We'll be doing special subject-wise test orthopedic questions from question number 151 onwards. Okay, so the question number 151 is: a 6-year-old female child presented with a valgus deformity of the right elbow. So the valgus deformity, okay, since 2 years, which is gradually progressive. She is feeling tingling in the ulnar 1.5 fingers, appears to be her ulnar nerve is going, and this injury has happened 2 years before, and after 2 years she is having features of ulnar nerve injury which seems to be tardy ulnar nerve palsy. She had a history of cast applied for 6 weeks after a fall on outstretched hand 2 years back. So 2 years back she had some sort of fracture around the elbow, for which she was given cast for 6 weeks. Okay, the probable fracture was supracondylar humerus, posterior dislocation of the elbow, lateral condyle humerus fracture, fracture of the medial condyle of the humerus. So first of all, we must understand that there are different growth areas around the elbow. Okay, the most important for us here is the lateral condyle area and the medial condyle area. Okay, now suppose if the lateral condyle area is injured, so what will happen? Growth will stop on this side, the medial side condyle will keep on growing and will become bigger as compared to the lateral condyle. So the elbow will go into a valgus alignment. Okay, now suppose your medial condyle area is injured but lateral condyle area is intact. So what will happen? The lateral side area will keep on growing, so the elbow will go into this position, the medial, towards the medial side there will be angulation which is called cubitus varus. Okay, now as said in the question, patient has got valgus angulation. Okay, so this appears as if the patient has got lateral condyle injury. Now lateral condyle is not growing anymore, medial condyle is growing, it has become bigger, the elbow has gone into valgus position, valgus. So there is a valgus deformity, but this deformity is progressive. That is possible only if this condyle has not healed, this is not united, and if there is a non-union of the lateral condyle. Okay, now if there is an injury to the lateral condyle which has resulted in the valgus deformity. Okay, so if the deformity is progressive, it will keep on increasing, the ulnar nerve will keep on stretching, okay, and will show the symptoms of ulnar nerve palsy, because the symptoms develop quite a lot time after the injury. That is why it is called tardy ulnar nerve palsy. So definitely patient does not have any injury to the medial condyle, the injury is to the lateral condyle. On the contrary, if injury to the medial condyle or supracondylar fracture happens, that usually leads to varus deformity, and if there is a supracondylar fracture, that will usually lead to varus deformity. Okay, if there is a posterior dislocation of the elbow, that will prevent the flexion and there will be a extension deformity. Okay, and if there is a fracture of the medial condyle of the humerus, that will lead to varus deformity. Okay, so the only fracture which can lead to valgus deformity in this question is the lateral condyle fracture. So the answer to the question number C is going to be lateral condyle fracture. So next question 152. The Trendelenburg test is performed mainly to assess the integrity of which of the following muscles. So they have given gluteus maximus, gluteus medius and gluteus minimus. We know gluteus maximus is the extensor of the hip joint, it causes extension of the hip joint. Gluteus medius and minimus both are abductors of the hip joint. So the answer cannot be A. So answer cannot be D. So the question answer has to be either B or C, because both are abductors of the hip. Now because gluteus medius is a bigger muscle, gluteus minimus is a very small muscle. Okay. So if I have to choose one answer out of these two, I will go with the gluteus medius, though the gluteus minimus is also a abductor of the hip joint, but this is a very small muscle as compared to the medius. So I think the answer of question number 152 should be B. Okay. Now have a look at this picture. Now you can see the 3 glutei they have shown here. Okay. So this is basically the gluteus minimus, okay, and this is the gluteus medius. Okay, both are attached to the greater trochanter, tip of the greater trochanter in this area. So whenever these muscles will contract, that will lead to abduction of the hip joint. Now this is the posterior view. If you see the gluteus maximus, it is attached to the posterior aspect of the femur. If this muscle will contract, that will lead to extension of the hip joint. There are 2 other abductors of the hip joint also. Okay. So these abductors are tensor fascial lata and sartorius. Okay. So if we have to choose one question out of these, gluteus medius is going to be the answer. If we have to choose 2 answers, then B and C both are going to be the answers. So I will go with answer B in question number 152. Question number 153, the most common complication of fracture neck of femur is, we know fracture neck femur has got very precarious blood supply. Okay. So if fracture neck of the femur happens, it can go into non-union. Okay. But so non-union is yes definitely an complication of the neck femur fracture, because blood supply is damaged. So though the fracture heals, the head will not survive and can lead to avascular necrosis, because the head has gone into avascular necrosis, it has become deformed, that can lead to arthritis of the hip as well. Malunion is a feature of intertrochanteric fractures, not usually neck femur fractures. Okay. So I will not go with, definitely will not go with answer D. Now all these 3 are complications of fracture neck femur, A, B and C, but among these, which is the most common complication of fracture neck femur? If we see incidence wise, avascular necrosis is the most common complication, then comes the non-union, then comes the arthritis. Okay. So if we have to choose the most common complication, that is going to be avascular necrosis of the femoral head. So answer to the question number 153 is going to be B. Okay. So the next question 154, dynamic compression plate, which is also called DCP in short, provides compression at the time of fixation when we are fixing the fracture in operation theatre, or during the weight bearing when patient is putting weight on the leg, or it provides compression both at the time of fixation and weight bearing, or none of the above. Okay. So whether the DCP provides compression during fixation or during weight bearing or both, for that we have to understand the principle of dynamic compression plating. If you see, basically this is the dynamic compression plate. If you see one hole of this plate where we are fixing the screws, okay, these holes are not round. You can see the hole are not round, the plate hole. So they are basically are kind of angled cylinder. So it is a kind of angled cylinder. So when we put a screw with a round head on this side, okay, like here, and we try to tighten the screw, so what will happen? Ultimately the screw will slide on this side. Okay. So this is the whole of this plate which helps in achieving the compression at the fracture site during surgery. So see how it happens. Now you see they are putting the screws away from the center of the hole, they are not putting in the center, and away from the center you have seen the holes are angled like this. So when we are putting a screw in this area and we are tightening it, the head of the screw will slide and it will come to lie in this area. Okay. So now whenever I am tightening this screw, so this whole assembly along with the plate will be pulled on this side. Okay. So bones will come closer. So when I am tightening this screw, the whole of this assembly will come closer. So that will lead to achievement of compression at the fracture site. You can see in this picture the fracture has nicely compressed. The screw which we have started here has moved on this side and lying in the center of the hole. So this is the feature of this hole which helps to provide the compression at the time of surgery. Once whatever compression we have achieved at the time of surgery, that is the only compression which can be which we can get with the help of dynamic compression plate. Okay. But if you see the dynamic hip screw, which is also known as DHS, so when we fix a intertrochanteric fracture with DHS, what happens, this proximal fragment, it has got a hold in the screw. The screw is holding the proximal fragment and this plate is holding the distal fragment of the femur, but this assembly is movable within each other. This screw can slide in this plate. So whenever patient will put weight, okay, so the proximal fragment will be pushed down and the ground direction will push the distal fragment up, so that will lead to compression at the fracture site. Okay. So when we are fixing it, we usually put a top screw over here which goes into this screw. Okay. So when we keep on tightening this screw, we can achieve at the compression at the time of surgery as well in DHS, and we can achieve compression when patient is putting weight on this as well. So DHS provides compression both at the time of surgery and on weight bearing, whereas DCP provides compression only at the time of surgery. Okay. So the answer of this question, that whether the DCP provides compression only at the time of fixation, not during the weight bearing, it is the DHS which provides compression during the weight bearing and during the fixation, not DCP. So the answer to the question number 154 is A, at the time of fixation. Was it DHS, then I would have gone for choice C, but as they have asked for DCP, so the answer is going to be A, at the time of fixation. So let us move on to next question. Question number 155. A 45-year-old gentleman was travelling in a car and sustained a head-on collision with another vehicle. Which of the following statements are not true regarding hip joint injury he may sustain? Okay. Now this is nothing but a dashboard injury. So when a patient is driving a car and he met an head-on collision, so the patient's body will keep on moving in the forward direction due to inertia of motion. Okay. So the sudden stoppage of the car will lead to will put a force on the knee joint. Okay. So that force will go through the femur and will exit at the hip joint and dislocating the hip in the posterior direction. Now we all know that there is something called sciatic nerve which is coming from behind. So when we are having a posterior dislocation of the hip, it is quite possible that sciatic nerve will be injured, and it is also quite possible that posterior lip of the acetabulum is fractured when head is dislocating out of the acetabulum. Okay. So let us have a look at the choices. It is associated with the posterior dislocation of the hip. Yes, that is true. We have seen they are asking about the not true, the false statement, the wrong statement. Sciatic nerve be involved due to leading to foot drop. Yes, involvement of the sciatic nerve is quite there in posterior dislocation of the hip which leads to foot drop. Avascular necrosis of the hip could be a later complication. Yes, dislocation of the hip has got very common complication in the form of avascular necrosis. The point of impact is on the greater trochanter. Now, if you see this picture, the point of impact is basically on the knee joints, not on the greater trochanters. Okay. So, the statement D is false, which is going to be the answer of this question. So, the answer to the 155 is D. Okay. So, this was regarding the dashboard injury. So, next question number 156 is ligament most commonly injured in ankle sprain is. Okay. So, let us have a look at the ligaments of the ankle joint. If you see from the side, basically there are three ligaments which articulate, which connect the fibula with the talus and calcaneum. The one is anterior talofibular ligament, talus and fibula, it connects the fibula and talus, and posterior talofibular ligament, it connects the fibula and talus, and there is another ligament which connects the fibula to the calcaneum, which is called calcaneofibular ligament. Okay. Now, the tibiofibular syndesmosis, the joint which is formed between the lower fibula and tibia, is called tibiofibular syndesmosis. It has got basically three ligament. The one is anterior, which is also called anterior tibiofibular ligament. Okay. There is called posterior tibiofibular ligament, and there is a ligament inside behind the anterior tibiofibular ligament, which is called interosseous ligament. Okay. The most common ligament which is injured in the ankle sprains is anterior tibiofibular ligament, sorry, anterior talofibular ligament, not tibiofibular. So, these terms are very confusing. Do not confuse talofibular with the tibiofibular ligament. Okay. If we see the choices, anterior tibiofibular ligament, no, this is ligament of the ankle syndesmosis. Posterior tibiofibular ligament, this is also ligament of ankle syndesmosis. Calcaneofibular ligament is not commonly injured, yes, can be injured, but not commonly. The most commonly injured ligament is anterior talofibular ligament. The anterior ligament which connects the fibula to the talus is the most commonly injured ligament. So, the answer to the question number 156 is going to be D. So, this is the most commonly injured ligament, the anterior talofibular ligament. Okay. The question number 157, K nail is ideal for fixation of which of the following fractures of the shaft? The choices are comminuted fracture of the shaft femur, fracture lower third of the shaft femur, transverse fracture around the isthmus, subtrochanteric fracture. Let us have a look at the features of K nail, how it lead to fixation. Now, if you see the inside of the femoral canal, okay, this area is the narrowest area. Okay, this narrowest area is called isthmus. Now, this is K nail. Okay, you can see the diameter of the K nail is same throughout. Moreover, if you are putting a nail in this femur, you cannot put a nail with diameter more than the diameter of the isthmus, which is the narrowest diameter of the femur. So, you can't put a nail bigger than this, because until you fracture or rupture this area. Okay. So, once you put a nail in this fragment, so that nail which is snugly fitting at the isthmus is going to be loose distally and going to be loose proximally. Okay. So, if we have fracture in this area, yes, that can be held very nicely with the K nail. Okay. But if we have fracture in this area or in this area, here the K nail is going to be loose, because we do not have any locking option with the K nail. So, the fracture fragment distal to this area or proximal to this area will not have rotatory stability. So, they can rotate over the nail. Okay. So, fixation of subtrochanteric fractures or fixation of lower third femur fractures is not ideal thing to fix with this. Okay. This is mainly used to fix the transverse or oblique fractures around the isthmus. So comminuted, so we will talk about this choice here. Fracture lower third of the shaft femur should not be fixed. Transverse fracture around the isthmus, yes, can be fixed. Subtrochanteric fracture should not be fixed. Regarding the comminuted fracture of the shaft femur, now see, if we have comminuted fracture anywhere in the femur and we put a nail inside it, okay, now we all know we don't have any locking option here, we cannot lock the K nail distally or proximally, okay. So whenever patient will start putting weight, and if patient is having comminuted fracture with multiple fragments, let us say around the isthmus or anywhere else, okay, so whenever patient will put weight, that fracture will collapse, so the femur will become short. So K nail is also not ideal for fixation of the comminuted fracture. You can see on this X-ray, the K nail is loose in the proximal fragment, it is snuggling fitting around the isthmus, it is also loose in the distal fragment. So if we have fracture around here, fracture around here, we should not fix with the K nail, we should only fix the fracture around the isthmus with the K nail. Comminuted fracture should not be fixed with the K nail, because on weight bearing that will lead to shortening of the femur. So the answer of this question is going to be C. The ideal fracture fixation with K nail is of the transverse fractures around the isthmus. The question number 158, which of the following statement is true regarding the anterior cruciate ligament? The choice A is anterior drawer test is more sensitive than Latchman test, Latchman test is more sensitive than anterior drawer test, both tests are equally sensitive, both tests are not useful. We all know we have two tests to examine the anterior cruciate ligament, okay. So anterior drawer test is done with the knee flexed in almost 90° of flexion, okay, but some patient who has got hematoma of the knee joint, they cannot flex their knee up to that much. So we do Latchman test in those kind of cases where you have to only flex the knee by around 20°, okay. So that will provide you provide you information whether the anterior ACL is intact or not. Among these two tests, the literature have shown that Latchman test is more sensitive as compared to anterior drawer test. So if Latchman test is giving you information that ACL is gone, then definitely it is gone, but that is not always true with the anterior drawer test. So Latchman test is more sensitive than the anterior drawer test for examination of the ACL clinically. So I will go for answer B to the question number 158, which says Latchman test is more sensitive than the anterior drawer test, okay. So next question is 159. Medial meniscus of the knee joint is injured more often than the lateral meniscus. That's yes, that is true, because the medial meniscus is more mobile, less mobile, thinner, attached lightly to the femur. If you see the anatomy of the medial meniscus, yes, that is bigger than the lateral meniscus, but it is firmly attached with the medial collateral ligament and with the capsule of the knee joint. So that is why whenever we are doing flexion, extension or rotational movements, so it can get stuck in between the femoral condyles and get injured. So because medial meniscus is less mobile, that is why it get injured more often as compared to the lateral meniscus. So that is why the answer to the question is going to be B, because medial meniscus is less mobile, and that is why it is more prone to injury, okay. So the answer for question number 159 for me is going to be B, the lesser meniscus is less mobile, medial meniscus is less mobile, okay. The question number 160, gamekeeper's thumb, okay. So they are asking what is gamekeeper's thumb, whether this is something which happens at the interphalangeal joint of the thumb, and there is a ulnar collateral ligament injury, or it happens at the interphalangeal joint and there is a radial collateral ligament injury, or it happens at the MCP joint, metacarpophalangeal joint, with ulnar collateral ligament injury, or this is happens at the MCP metacarpophalangeal joints and there is a radial collateral injury. Now, gamekeeper's thumb is something which is very common in sportsmen. Let us say whether it is cricket, if you are catching a ball, what will happen if you are trying to catch, your thumb will go into this direction. Okay. So, what will happen, mainly the metacarpophalangeal joint will be injured. Okay. The collateral ligament which is on the ulnar side of the metacarpophalangeal joint will be injured, leading to metacarpophalangeal joint injury with the ulnar collateral ligament injury, which is called gamekeeper's thumb. If we see the choices, the choice C says thumb metacarpophalangeal joint with ulnar collateral ligament injury. This is also known as skier's or skier's thumb. Okay. So, answer to the question number 160 is C. Let us move on to question number 161. Apart from deltoid, which rotator cuff muscle is supplied by the axillary nerve? So, they are asking what are the muscles which are supplied by the axillary nerve. One, they have already told, deltoid. They are asking which another muscle is supplied by the axillary nerve. If you have a look at this picture, the axillary nerve basically gives branches, one which goes and supplies the deltoid, and one to the another muscle which is on the back side of the scapula in this area, which is teres minor. Okay. So, the deltoid and teres minor are two muscles which are supplied by the axillary nerve. So, out of these rotator cuff muscles, teres minor is the muscle which is supplied by the axillary nerve. So, the answer to the question number 161 is D. So, question 162, which of the following is not a feature of carpal tunnel syndrome? We all know carpal tunnel syndrome is compression of the median nerve under the volar carpal ligament in the wrist joint. So, once that happens, what will happen? All the muscles of the dinar eminence, they will not be functioning properly, plus there will be loss of sensation in 3.5 fingers on the radial aspect. Okay. So, when these muscles of the dinar eminence, they are responsible for carrying out the fine movements like writing, buttoning, unbuttoning. Okay. So, these are called fine movements. If these muscles are damaged or these muscles are not working properly, we will have clumsiness in doing the fine movements. Okay. So, the answer, so they are asking which is not the feature. The one, say clumsiness in doing the fine movements, yes, that will happen if we have carpal tunnel syndrome. Altered sensation in the lateral 3.5 finger, yes, we know that the ulnar nerve supplies 1.5 fingers and the median nerve supplies 3.5 fingers on the lateral aspect or radial aspect of the hand. Okay. So, the other choice is wasting of the adductor pollicis, that is not true. So, basically adductor pollicis is a muscle which is supplied by the ulnar nerve. This is not supplied by the median nerve. So, the abductor pollicis, yes, is supplied by the median nerve, but here they have asked adductor, double D. So, that should be the answer. Night pain, yes, during the carpal tunnel we get the night pains, because when we are sleeping our wrists usually go into flexion. So, that will lead to crowding of the content of the carpal tunnel. The pressure inside the carpal tunnel will increase and patient will have pain at night and they will start shaking the hand like this to relieve the symptoms. So, the answer to the question number 162 is going to be C, wasting of the adductor pollicis. Adductor pollicis is a muscle which is supplied by the ulnar nerve. So, the answer to the question 162 is C. Question 163, Herverdens nodes are seen in MCP joints, proximal interphalangeal joints, distal interphalangeal joints, both proximal and distal interphalangeal joints. So, what are Harvard's nodes basically? Harvard's nodes are basically arthritis of the distal interphalangeal joint. So, arthritis of the distal interphalangeal joint will lead to osteophyte formation, and there will be swelling of the distal interphalangeal joint, which is called Harvard's nodes, and this is a feature of mainly of osteoarthritis. Another node which are present on the proximal interphalangeal joints are called Bouchard's node, which are usually seen in rheumatoid arthritis. So, they are asking Harvard's node, where do they present? They are present over the distal interphalangeal joints. Okay, so answer to the question number 163 is going to be C, distal interphalangeal joints. Question number 164, which of the following is not a feature of rheumatoid arthritis? All of these are feature of rheumatoid arthritis except one. So, let us have a look at this picture. Okay, we can see Z thumb deformity is there. You can see buttoner deformity of the thumb, hyperextension of the interphalangeal joint. You can see the swan neck deformity. There is a hyperextension of the proximal interphalangeal joint and flexion at the interphalangeal joints, which is called swan neck deformity. This is also a feature of the rheumatoid arthritis. Now, you will see there is a ulnar deviation of all the metacarpophalangeal joints. Okay, so the proximal phalanges have gone into ulnar deviation. Okay, so this is also a feature of the rheumatoid hand. So, another feature you will see at the wrist is radial deviation. So, the hand will move into radial side. So, radial deviation at the wrist joint, ulnar deviation at the metacarpophalangeal joints, swan neck deformity, buttoner deformity, and Z thumb deformity. Another deformity we have just seen in the last question is Bouchard's nodes, which are commonly seen in the proximal interphalangeal joints. Okay. So, Harvard's node are features of osteoarthritis, not rheumatoid arthritis, wherever Bouchard nodes are features of rheumatoid arthritis. So, in the question number 164, Harvard's node definitely a feature, not a feature of rheumatoid arthritis, as they are usually seen in osteoarthritis. Swan neck deformity, yes, can be seen in rheumatoid arthritis. Ulnar deviation of the fingers at MCP joint, yes. Symmetrical reduction in joint space, yes, can be seen in rheumatoid arthritis. So, answer to the question number 164 is going to be A. Okay. So, question number 165. The diagnostic criteria for ankylosing spondylitis include all of the following except. So, we must know what is the diagnostic criteria for ankylosing spondylitis before solving this question. So, if you see modified New York criteria for ankylosing spondylitis, it has got two things. One is clinical criteria, another is radiological criteria. Now, there are three things in the clinical criteria. First of all is low back pain, which is there from more than 3 months. It will improve with exercises, but will not improve by rest. There will be limitation of spine movements, reduction in the movements of the spine in both frontal and sagittal plane. There will be limitation of the chest expansion as compared to the normal values for that age and gender of the patient. The radiological criteria includes sacroiliitis on the X-rays. Now, from these criteria, how you are going to diagnose ankylosing spondylitis? It is definitely ankylosing spondylitis if radiological criteria is present, I mean sacroiliitis, or at least one clinical criteria out of low back pain, limitation of spine movement and chest expansion is present. Probably it could be ankylosing spondylitis if out of clinical or radiological only one thing is present, either clinical criteria is present alone, and there is no radiological criteria, or only radiological criteria is present and there is no clinical criteria. If you see this criteria, HLA positivity has not been mentioned anywhere to diagnose ankylosing spondylitis. So, HLA B27 positivity is not included in diagnosing criteria for ankylosing spondylitis. Other thing, limitation of the movement of the spine, yes, it is included. Limitation of the chest expansion as compared to the normal age and gender is included. Sacroiliac joint involvement is included in the radiological criteria. So, answer to the question number 165 is going to be A. HLA B27 positivity is not included in criteria to diagnose ankylosing spondylitis. So, question number 166, which of the following is not a diagnostic criteria for rheumatoid arthritis according to American Rheumatism Association? So, we must know what they have given in the criteria to diagnose rheumatoid arthritis. Okay. So, this criteria has got 7 points. Okay. The point first is morning stiffness, okay, which stays here for more than 1 hour before maximal improvement, means the patient will complain of morning stiffness, he is not able to make the fist. Okay. So, that thing will be there for at least 1 hour. So, as long as patient will start doing the activities, that stiffness will improve. Another thing is arthritis or swelling of 3 or more joints. Okay. Then symmetrical arthritis or swelling, it basically they are talking about synovitis. Okay. Arthritis of the hand joints, presence of rheumatoid nodules, presence of rheumatoid factor, and radiographic changes which are present on X-rays, they are included in criteria to diagnose rheumatoid arthritis. So, if there are 4 or more than 4 of the above 7 criteria are present, you call it rheumatoid arthritis. Criteria 1 to 4 must have been present for at least 6 weeks. So, these has to be there for at least 6 weeks. If it is less than 6 weeks, then that is not included. Okay. Now, we will go back to the question, raised rheumatoid arthritis factor, yes, it is included. Symmetrical swelling arthritis for at least 6 weeks, yes, that is included. Symmetrical muscle weakness has not been included in diagnosing the rheumatoid arthritis. Rheumatoid nodules, yes, it has been included. So, as for the criteria, the answer to the question number 166 is going to be C, symmetrical muscle weakness is the answer to question number 166. The question 167, all of the following are features of giant cell tumor of bone except. Okay. So, the most common site in axial skeleton is sacrum. Yes, that is true. In axial skeleton, it most commonly involves the sacrum, whereas in appendicular skeleton, it involves the distal radius and bones around the knee like distal femur and proximal tibia. It is located in eccentric position along the long axis of the bone. Yes, eccentric position is one of the criteria to diagnose it as GCT. Crosses the physis. Basically, giant cell tumor is present, is a tumor of the mature skeleton. If it is present in immature skeleton, then this is not called giant cell tumor. Okay. So, then there is no question of crossing the physis. If it happens in patients or it occurs in patient of mature skeleton where physis no longer exists. Okay. Metastasis to the lung, yes, it is one of the benign tumor which is known to metastasize to the lung. So, I think the answer to the question 167 should be C, crosses the physis. So, giant cell tumor of the bone occurs in young adults from 25 to 40 years of age. The physis must be closed for the radiological criteria to be met. Okay, so physis must be closed. If it occurs in the open physis, then you don't, then that is something else. So other criteria which can be seen are epiphyseal location, but the articular surface usually doesn't crosses the articular surface, is mostly eccentric with non-sclerotic margin. The most common site of the appendicular skeleton is distal femur, proximal tibia and distal radius. The sacrum is the commonest site in the axial skeleton. So we'll go with answer C to the question number 167. Now let's move on to question number 168. Which of the which is the most common site of pelvic apophyseal avulsion fracture? Okay. Now if you have a look at the pelvis diagram of a adolescent kid, usually all the apophyses which are there around the pelvis, they usually fuse around the age of 14 to 16, except the physis of the ischial tuberosity, which is the last one to fuse. That is why whenever you are doing flexion activities like kicking the ball, that can lead to avulsion of the ischial tuberosity apophysis. So avulsion of the ischial tuberosity apophysis is one of the commonest thing to happen. So answer to the question number 168 is going to be D, the ischial tuberosity. Question number 169. A 60-year-old man with history of long-standing diabetes mellitus presents with painless swollen right ankle joint. So this patient has long-standing diabetes. We all know diabetes mellitus, if it is there long-standing, it can lead to peripheral neuropathy. Okay, so once the pain sensations are lost and patient has got peripheral neuropathy, uneven or unwanted weight bearing can lead to damage to the joints. X-ray of the ankle shows destroyed joint with large number of loose bodies. So they are basically talking about the neuropathic joint. Okay, so neuropathic joints are known as Charcot joints. Okay, so Charcot joint basically is a progressive destructive arthritis arising from loss of pain sensation and proprioception. If these sensations will be lost, patient will not be able to protect his ankle or knee or any joint from any sort of uneven weight bearing. Uneven weight bearing will ultimately damage the cartilage at different parts and will lead to arthritis of the joints. Now joint lacks normal reflex safeguard against abnormal stretch and injury. So most commonly these can be caused due to diabetes mellitus, tabes dorsalis, leprosy, syringomyelia, meningomyelocele and chronic alcoholism. So the neuropathic joint is also known as Charcot joint. Most common cause, one of them is diabetes mellitus, which is there from long standing. So answer to the question number 169 is going to be A, Charcot joint. So question number 170. Which of the following drug causes osteomalacia? These are some of the anti-epileptic drugs. Okay, so out of these, the phenytoin, phenobarbital or primidone, what they do, they induce the microsomal enzymes P450. So induction of this enzyme, what will do, it will increase the conversion of the vitamin D to a inactive form by the liver microsomes. Okay, so because vitamin D has become inactive, okay, so bioavailability of the vitamin D will be decreased. So when vitamin D is less, so there will be less absorption of the calcium from the gut. So that will ultimately lead to less absorption of the calcium from the gut. Okay. So, this will ultimately results in osteomalacia. So, the patients who are usually on anti-epileptic drugs from the category phenytoin, phenobarbital or primidone are usually more prone to have osteomalacia. So, these kind of patients who are on these drugs should be started on vitamin D as well. Okay. So, phenytoin is one drug which the long term use of which can lead to osteomalacia. Okay. So, this was the today's session. Rest of the question from subject type wise test will be doing in the next session. Thank you.